Now we're going to talk about the micturition reflexes. So micturition is going to involve the storage of urine and also the emptying of the bladder. So we're going to start out with just looking at the innervation. Um, when we look at the renal system, before we're getting to the bladder, the renal system is really going to have mainly sympathetic innervation, which you might remember from the endocrine lecture is important because at the center of the adrenal glands, the adrenal medulla is going to be making catecholamines. Then we're going to put this together with the micturition reflex, which is going to involve the bladder associated with the kidneys. But just to begin with, just going over the renal innervation, the medullary site that is going to oversee most of the renal outflow is called the rostral, which means towards the beak, so towards the front of an animal's face, ventrolateral, so on the ventral surface to the side, medulla. And the rostral ventrolateral medulla is going to be the outflow center going to the sympathetic nerves that will then innervate the kidney. You can see a close-up of this over on the left side. So we're going to be looking at the vertebrae, which will then send their preganglionic neurons out to the specialized ganglia. So we'll have the celiac ganglion, superior mesenteric, aortocorneal, posterior renal ganglion, and then those postganglionic nerves will go straight out to the kidney for innervation. There is no parasympathetic input associated with the kidneys. But there is going to be some parasympathetic and sympathetic interplay with micturition. So this has now become a little bit blurry, so let me see if I can make this a little bit more readable. There we go. So what we're looking at here, well, that still looks blurry, is this basic micturition response. So there's a couple of important things that we have to think about with regards to the bladder. It is the simplest organ in the body in that its job is to fill and then empty. So we have this hollow organ. So the bladder is made mostly of muscle. And this is a large muscle called the detrusor muscle. And the main job of the detrusor muscle, like all muscles, is to contract. And the first time you'll see contraction is when the bladder is full. So that's what you see here. And when the bladder fills, it's allowed to fill without changing the volume or the pressure inside of the bladder because of the associated rugae. So the detrusor muscle first contracts very weakly when the bladder fills. And that's an important thing to remember, that that's when the detrusor muscle is supposed to make its first initial contraction. Then we're going to have a couple of associated sphincters. There is an external sphincter, which is under somatic muscle control, meaning that it is skeletal type muscle. It can be controlled. And in the meantime, when the bladder first fills and contracts very weakly, it's going to send a message up to the brain that there is going to be a storage of that urine until it's convenient to empty or void. In order for the voiding reflex to occur, we're going to have a stronger, more extended contraction of the detrusor muscle for full emptying of the bladder. And there also needs to be a release or relaxation of the external sphincter to allow the bladder neck to empty. So as we mentioned, the formation of urine is built upon the premise that the blood is flowing through the kidneys, going from really large vessels to small vessels, and then at a very high pressure will be pushed through these spaces in the glomerulus. So All of this filtrate then pushed out of the bloodstream will be gathered into those tiny nephron units, flow down those calyces systems, the minor and major calyx, into the renal pelvis, and then small peristaltic contractions will move this filtrate, these waste products now, down through the ureters into the bladder. And again, the bladder's job is going to be first to fill and then to empty. And when the bladder empties, it will empty through the bladder neck. And we'll take a closer look at that in just a second. And then it will go through the posterior urethra. So the urethra is right underneath the bladder neck. And in a female system, the end of the urethra, the posterior urethra, that's going to be the end of the system. In males, there's also the penis, so the external meatus will extend the posterior urethra, and that would be the end of the voiding response. So here is a closer look at male and female bladders, and this is very important. So it is way more common for females to have bladder or urinary tract type infections, urethritis, UTIs. So that's an infection of the urethras. And then a cystitis, so cyst in this case is referring to the bladder. This is the bladder here. So cystitis is an infection of the bladder. And most bladder infections take place in this area that's labeled here called the trigon region, which, just as we mentioned at a molecular level with the renal papillae and the pyramids, the trigon is really the funnel neck that will funnel the urine out of the bladder and then into the urethra. So the reason why you see far more infection in females and males is because the opening to the urethra in females is very close to the opening of the bladder, and then also this internal area of the urethras. In males, because there's an extended length of the urethra, even if bacteria start migrating towards the bladder, every time urine flows through this urethra, urine is acidic and it helps clear out that bacteria. And the rule of urine is sterile as long as it's moving. So it's very important that urine be moved and also that the bladder be emptied completely. If there is stagnated urine because of incomplete bladder emptying, that's more likely to pick up bacteria. One important thing about bacteria, remember, is that it makes gas. So it'll go through this little fermentation type of process we see with lots of other like foods, fizzy things, soda or beers, fermentation, and gas will then fill up the bladder, which is why you see in UTIs and bladder infections that there is a constant contraction of the detrusor muscle because the gas is filling up the bladder, giving the sensation of fullness. But when the individual goes to void, there's actually a very small urine volume. So just like most things in the body, mucus is the same way. Urine is sterile as long as it's moving. So this can be a problem with incomplete emptying, and this is going to be something associated with age in males because of the prostatic urethra. So in this picture, it looks like there is a continuous like lumen through the bladder all the way through the system here. And what you'll see in reality is when you look at the prostate, it almost looks like a donut. And there's a hole in the center, which is the prostatic urethra. And you might know that the prostate grows with age. So as there is growth or hypertrophy of the prostate, it will grow in all directions. And you'll eventually see difficulty moving urine throughout the prostatic urethra. And then urine backs up, and then you see infections. So just again, going over these different pieces that you should definitely know. So the detrusor muscles, this very thick muscle that makes up the majority of the bladder, it's its job to contract when the bladder first fills, and then it also contracts very strongly to cause the voiding. These are the openings to the ureters, so they empty out way down here to the bottom, and that bottom area is the trigon region, trigon. Then there are two sphincters. There's the internal sphincter, which technically isn't a true sphincter. It's really just a thickening of muscle in this area. And this is all smooth muscle. So we do not have conscious control over the internal sphincter. However, the external sphincter, which is within the urogenital diaphragm, oh my goodness, oh, my mouse is working backwards today. This external sphincter is skeletal muscle, so this is under conscious control. Males in general have a stronger control over their external sphincter just due to the anatomy of the system. So the really important key here is pathology-wise, with infections, the short distance between the outside and the inside of the body makes it more likely for external bacteria to be transferred to the urethral opening than it happens to be in male. So just a simple anatomical difference. The other pathological difference is the prostate gland, which can cause urinary obstruction. All right, so we've got the body of the bladder. The main pieces will be the body, which will be the lining, the adventitial lining on the outside, the endothelial lining on the inside, and then the larger muscle lining, the detrusor muscle, and then the bladder neck. So these are the different pieces that we have spoken about. Now we're looking at everything that I've mentioned just previously. The detrusor muscles, this large internal muscle lining the bladder underneath the endothelial tissue, that's smooth muscle. When the detrusor muscle contracts, that is not under conscious control. The only thing that can be controlled is these external sphincters in the urogenital diaphragm. Again, the internal sphincter, it's muscle fibers in the bladder neck area, not a true sphincter, just a thickening of the walls of muscle tissue. There's no conscious control. And it does have a natural tone, a natural just basal baseline level of tone, which should keep the bladder neck empty. When there is urine that's allowed to move into the bladder neck and it stagnates there, it turns the smell into one of more nitrogenous waste. So when somebody has true incontinence, so urinary incontinence, the urine that leaks out does smell more nitrogenous. That means it's been stagnating in the neck. And as we mentioned, the last piece is the urogenital diaphragm. So there is the skeletal muscle component there called the external sphincter. There is voluntary control of that. And sphincters, remember, they are like belts. So they contract in a circular fashion. So this would be a relaxed sphincter. And when they contract like this. So this, in order to, like if this was contracted, if we contracted our external sphincter, that would close up this opening. So in order for voiding to occur, this has to be a relaxed lumen. Otherwise, there won't be the outflow of urine. Again, males have better voluntary control of the external sphincter just through anatomy than females do. And then that control from females of the external sphincter does become compromised with childbirth, which stretches out the urogenital diaphragm area. Okay, so here is the innervation. As I mentioned, unlike the kidneys, which have only sympathetic input, with the bladder, there's going to be both parasympathetic, sympathetic, and then also somatic. We have the pudendals, which are going to provide somatic outlet for conscious control over the external sphincter. So the parasympathetics We know S2, 3, 4 are the levels, the sacral levels associated with the parasympathetic. And those parasympathetic inputs, they can help out by working to send nervous signals to the body of the bladder to help out with storage. So that's during rest and digest. So you're in class, you have to go to the bathroom, you look at the clock and you think, I could probably wait. That's your storage reflex, right? So that's going to help you just store that under times where you're just resting and digesting. And there's also parasympathetic inputs from the lower sacral regions to the bladder neck area, which is important for the micturition response. The sympathetic efferents, they come out to these specialized ganglia. So we said like celiac ganglia, places like that. So they're going to come out to the ganglia. That's our preganglionic. Oh no, I have got to redo my mouse because it is a smart mouse and it's working backwards and it's making me really frustrated. So this is coming from L2 going out to the sympathetic ganglia, sending sympathetic efferents out to the body of the bladder, to the lower portion associated with the trigon region, but basically helping with a full innervation of all areas of the bladder for voiding and micturition. As I've mentioned, the pudendal is somatic. The somatic nervous system is associated with muscle. So just like all skeletal muscle, the pudendal is innervation going to skeletal muscle. So the sympathetics, they mainly innervate blood vessels. They don't have a ton to do with the contraction, but they do modify how much blood flow is needed to maintain storage. So if there was a true sympathetic outflow, sometimes when people are scared or anyone is scared, they can urinate unexpectedly. That's because of an interruption to this parasympathetic storage response, and then a shifting of blood flow away from the energy and the flow that's going to preserve the storage response that will be interrupted in some cases and cause storage to turn into voiding. Okay, innervation again. So here's our different levels of sympathetic, parasympathetic, S2, 3, 4, the somatic nerves, the urethra, external sphincter. This is showing you which receptors are in that area, which should hopefully make sense by now because we talk about these a lot. So we've got cholinergic receptors, so that means acetylcholine can bind to them. And if you remember, in the tissues, the receptor subtypes are muscarinic type receptors that lie in the tissue beds. So acetylcholine binds to muscarinic type receptors. There's also beta adrenergic receptors, beta for receptor type, and adrenergic means adrenaline binding. We've moved from the name adrenaline to epinephrine or norepinephrine. So beta receptors bind norepinephrine. And there's also alpha adrenergic receptors here. So alpha, those also are adrenaline or norepi type receptors. Remember that if it's an odd, I don't know, I drew that line. If it's an odd number receptor, it's an excitatory receptor. If it's an even number, like alpha 2 or beta 2, then it's an inhibitory receptor. So this would mean like a beta 1, it would bind, it would cause that muscle to contract. If it's an even, like a beta 2 receptor, it would bind and cause that muscle to just chill. It won't do anything. Okay, so we've got muscarinic receptors associated with parasympathetic release of acetylcholine, and we have both alpha and beta receptors here to bind norepinephrine. Why is that important? When you have patients on medications that are involved with the release of acetylcholine with norepinephrine or the blocking of that. So if they're on an anticholinergic, so let's say they're on medications for IBS, you take anticholinergic medications. that's going to block acetylcholine. That means you can count on there being parasympathetic effects. If somebody's on a beta blocker because they have hypertension, that means those beta receptors in the bladder will be affected. Okay, people take alpha-2 drugs for things like hypertension or anxiety. So there's a drug called clonidine, which is an alpha-2 blocker or agonist. So you're going to have those alpha effects there. So when you're looking at side effects of medications, they're not magic. They don't just come out of nowhere. They're associated with the normal physiology having to do with the receptors embedded in the region and whether or not you're turning on or off creation of that neurotransmitter. So when alpha receptors in this area are stimulated, we're going to see contraction. So if we're going by our odd-even rules, if we had to guess, we would know that it would be an alpha. If it's an odd number, there's contraction. So that means it's probably an alpha 1, a 3, or a 5. Usually we just talk about alpha 1. So let's go with that. Muscarinic stimulation, that's sustained contraction. And as we said, this is our rest and digest parasympathetic nervous system. So sustained contraction, that would be your storage response. That would be the detrusor muscle contracting to say you're going to have to go to the bathroom and pee eventually, but you've got 10 minutes left in class, so that's cool, we'll wait. That is going to rely on acetylcholine binding to muscarinic receptors. So this is storage, whereas down here, alpha stimulation with contraction, that's more so for voiding or actually urinating. Pudendal, we know that skeletal muscle, that's only going to involve what's going on with that external sphincter. We generally gain control over the external sphincter usually by the age of 2. Before that, people just urinate. Babies just pee in their diaper. If people have spinal lesions that are lower and there's compromised pudendal function, then they're going to have difficulty or a complete inability to contract the external sphincter, and there will be free flow of urine. Like other smooth muscle-coated organs that act as a syncytium, there are pacemaker cells in this area which start a wave of contraction. And when the calyces are stretched, so once filtrate starts to leave the pyramids and go into the calyces, that stretch there will start to generate some action potentials so that we initiate these responses. So pacemaker cells means that they run themselves. They don't have to be activated that strongly. It's a very simple thing. Either like in the heart, you have these and it's just triggered whenever calcium comes in. In the bladder, it's triggered when the calyces are stretched. So that means it runs itself. There's not a lot of oversight by the brain, and it's a really great and very simplistic way of getting a nice reflex. So here's your Micturition reflex. So here are the stretch receptors embedded in the bladder wall. We've already talked about the nerves there. So we've got pudendal nerves going to act out to the sphincters. In the parasympathetic system, we have the ganglion for the tissue embedded within the organ itself, and that would have nicotinic receptors on it, because remember, the preganglionic neuron that releases acetylcholine, or sorry, that would be way down here, releases acetylcholine, and that acetylcholine binds to nicotinic type receptors, and then the postganglionic neuron also releases acetylcholine, and that would bind to muscarinic type receptors. So let's start at the beginning. Here's these stretch receptors embedded in the wall, and the bladder's job is to fill. And once that bladder is full, there is an afferent response set up by the sensory fiber in the nerve. And remember, this is going to be associated with storage at this point. So all this is the sensation that the bladder is full. Those sensory fibers are going to send messages forward. The local reflex, not involving the brain, this is a diverging pathway. Neurons go in one direction and the other. The divergent pathway, this local reflex, is there's a stretch, then this is going to respond by saying, okay, let's save this urine and not pee our pants right now. So that's just going to be sensory input to the cord, and then parasympathetic outflow, acetylcholine release, binding with muscarinic receptors, and getting this nice initial weak contraction of the detrusor muscle. So this is our local reflex, local, cord only, organ cord. Sensory in, bladder is full, parasympathetic out. Let's contract and store this urine. At the same time, because this is God bless America, at the same time, because this is a diverging circuit, we had one circuit coming out here to the parasympathetic. The other divergence is going to start to travel up to project to more homeostatic centers. So the sensory afferent enters the cord. One side is going to come out and communicate with parasympathetic outflows. The other one is going to send its message. This would be the first order neuron. 1. Here's 2. That's going to go from the cord up to the thalamus. And you hopefully remember that all sensory information, its way station, the first place it stops is the thalamus. It's called thalamic relay. So that's where the homeostatic message is entered, like we're in or out of homeostasis. And then the third order neuron is going to project to the cerebral cortex, that part of the brain that we, that we think with, to help us make a decision about, what should we do? Should we pee our pants now? Should we leave class right now and go to the bathroom? But we can make conscious decisions about that. So before the age of 2, when children are very young or with a spinal cord injury, we're only dealing with this local reflex. Bladder is full, let's contract the detrusor muscle. Once people get older and have an intact spinal cord, then we will have the brain involved. So first order neuron is sensory, second order is interneuron between the cord and the thalamus, and third order is a message from the thalamus to the cerebral cortex to make a decision about when to enter. So as I mentioned, first step, bladder fills, stretch receptors, cause a weak contraction through postganglionic efferents. The contraction at the same time, it's going to slightly relax this whole internal bladder neck. So this internal sphincter will decrease its basal tone so that urine is going to prime essentially and start to sit just waiting to be let out in the posterior urethra. However, the cortex can inhibit this and say, instead of going into this person's pants, why don't we wait to relax that external sphincter and do that when it's convenient to micturate. So the pudendal nerve can be inhibited by your own brain making the decision that it's not convenient to defecate at that moment in time. Not defecate, sorry, micturate. Okay, when it is time to micturate, then you need to open up the sphincter. Okay, so we talked about this already. So the simple spinal reflex. Okay, so we've got the detrusor muscle contracting, that internal sphincter opens, and that's all storage now, right? So we're going to have parasympathetic activity so that we have a storage reflex, and that's all going to be initiated by these stretch receptors. Bladder fills, there's a stretch, we get this local activity. The parasympathetic nerves weakly contract the detrusor, internal sphincter opens, allows the outflow. But we can still have the brain override that activity. So this is the spinal reflex, but don't forget we have this divergent receptor after the age of 2. So not only does the stretch receptor tell the cord that we have to do something, those stretch receptors go to the brain. So there's 2 different centers that help control what's going to happen. We can either store the urine and inhibit micturition or voiding, or we can actually micturate. So those higher brain centers, those things you think within your brain, they will allow you to kind of go signal to whatever one is appropriate. So the micturition center is the actual voiding response. And then the storage center, that's your parasympathetic, let's hold on to the urine until it's convenient. And it inhibits micturition by acting on the 3 spinal efferents. The somatic nerve, that pudendal, we're going to inhibit the parasympathetic, like sympathetic, all of this working together. This pontine storage center can kind of block that natural tendency for the bladder to fill and then just naturally empty itself. Instead, we can see micturition happen when there is really just somatic nerve activity. When the person moves to where it's convenient to void, lower the motor neuron activity, so physically relaxing the external sphincter, opening up that sphincter, and then there is the outflow of urine. So that is the story about voiding or urination. And we call that micturition. You should definitely know that reflex. This is a really great slide showing you everything, but this is the simplest one. I mean, it's a pretty simple reflex. Bladder fills, bladder is going to store, or bladder is going to empty, depending upon which thalamic center is going to be activated in this response. Okay, and when I speak with you next, it will be about glomerular filtration. All right, everyone.